Okay, thank you so much, colleagues. This is the last part, just to tie up everything that, or most of what we have discussed today. Let me present the case of Shumani, who is a 33-year-old newly diagnosed HIV positive male who was started on ART with tenofovir, emtricitabine, and efavirenz 4 days ago with a CD4 count of 35. You are screening him for opportunistic infections prophylaxis eligibility. Colleagues, what questions would you ask the patient? Recently started ART 4 days ago, and you have a CD4 count of 35, and you are assessing him for eligibility for prophylaxis for opportunistic infections. What do you need to ask and ascertain?
Someone may raise their hand or type in. We would appreciate some form of feedback at this point in time. Thank you.
Any suggestions, colleagues? What are you worried about? Which opportunistic infections bother you as you initiate ART? Any offers? Shall I prompt? I see this. Hi, ma'am.
I just wanted to add to the question that maybe if it does help, that maybe we should also think about this is a person who was already started on ART. So in terms of when you start ART and this is the data that you've been given, what are the considerations? Maybe think back to your guidelines.
Okay. Please come closer to
you are not audible.
You are not, yeah.
Me?
Yes.
Oh.
Yes.
I was saying the question, it's no no. I was saying that the question is saying it's a person who's newly started on ART 4 days ago and the CD4 count is 35. So I'm just saying that, you know, if it helps, that maybe we should also think back to our guidelines, our ART guidelines. What are they saying we must do when we have a patient with a CD4 count this low? What are the considerations? So when you're answering this question, what are the clinical considerations? I was just trying to help to get the conversation going.
Thank you very much, Nobulunga. You helped. I've got some comments on the chat. Zingiswa is saying, ask about alcohol, ask about diabetes, and Galaxy S8 is saying screen for TB, and Muzi agrees that we need to screen for the patient for active TB. And Galaxy S8 is also saying follow up on the cryptococcal latex antigen test. Colleagues, I would agree first with the screening the patient for TB. That is a must. We are talking which opportunistic infections. So screening for TB, absolutely. Follow up on the cryptococcal latex antigen test, absolutely, colleagues. The CD4 count is 35. The lab would have reflectively, it's called reflectively, yes, reflex screening. They would have done reflex CLET screening to exclude, so that we can exclude cryptococcal meningitis, absolutely. And Zingiswa is saying, ask about alcohol, diabetes. Zingiswa, I also agree. Colleagues, I am assuming that we will take a history, a full history covering TB symptoms, but we also, colleagues, remember, need to stage the patient, the patient as well. So we need to ask questions and do assessment that would cover that would allow us to stage the patient appropriately. And we would also need to check for any medication that they are on that could be a problem later on, whether with ARVs or with any other prophylaxis we want to implement, and also other medical conditions, including when we talk medication, let's not forget the herbs and other over-the-counter medication. Sean Hamilton is saying, ask for cough and duration, absolutely. And remembering that any duration of cough is worrisome for this client. Loss of weight, loss of appetite, night sweats, TB infection, history, or any TB contact. Great. So colleagues, in terms of assessments, can you tighten it up to say what assessments and tests are you going to do, if any? Huh? We've got an ALT from Muzi. Muzi, I'm going to ask further, why are you looking to do an ALT? Gene Expert Ultra. Aha, I'm going to throw it back to the group. Colleagues, I'm seeing tests coming through. I shall accept them with reservation. We need to have rationale for the tests. Muzi, please, or anyone, colleagues, please comment on doing an ALT for this client, why it would help us and whether it is indicated or not. And let's also comment on the Gene Expert Ultra.
You may also raise your hand so that if you don't want to type, yes.
Right, colleagues, I've got full physical assessment, Jacquard, chest. Yes, absolutely. That one doesn't even need motivation. It's an absolute standard of care. I want to engage on the collecting sputum for Gene Expert. Colleagues, please tell us what are the indications for the tests that we are doing. So I'm hearing the client was initiated on ARVs recently, thus ALT was done. Okay, I accept. So we would follow up the result of the ALT that was done. Thank you. Oh, it gets interesting. LEM test. Colleagues, please don't forget to talk about the Gene Expert Ultra. Why are we doing it? And now we've got the LEM test in the mix. Why are we doing it? Colleagues, let me ask, Renee is putting a spanner in the works. She's saying ALT is not indicated for all, but based on the assessment, then it is recommended. Colleagues, let me ask, when we initiate clients on or patients on ARVs, are we supposed to do an ALT at baseline? Let's answer that question first. We'll come to the others. ALT, are we supposed to do it at baseline? Siatemba is saying no, only for nevirapine-based regimens. Dr. Mawela?
Yes, ma'am. Is it Siatemba? Siatemba.
Please rule on this one.
Yes,
Dr. Mawela is our HIV guru. Come.
So Siatemba is, I would support Siatemba's comment, because remember, in doing baseline tests for ART initiation, there are standard things that you do for all, you know, like weight, TB screening, WHO staging. So it's for all patients, you know. Then there are tests that you do based on the regimen that you are prescribing for the patient. So in this scenario, Shumani was prescribed tenofovir, emtricitabine, and efavirenz. Actually, if there was a baseline test that needed to be done, it would have been a creatinine clearance. ALT only for those when a therapy is started. So it's not, so it means here 4 days ago, ALT was not done, but also today, unless if there's a specific reason, Shumani has a history of liver problems or something like that. So it's unlikely that it would be indicated, the ALT. We only do it when a patient has symptoms or complaints and we suspect liver toxicity. So it's not a standard monitoring test. Yeah.
Okay, thank you, Dr. Mawela. Zingiswa at 121 suggested to us that we need to ask about alcohol. So I was hoping maybe someone would pick up on that. Remember, there are certain, if we are considering a LTBI preventive therapy, by the way, colleagues, that's when we would need to look for high-risk groups that would require a baseline ALT before we initiate preventive therapy. So colleagues, on the issue of ALT, we lay it to rest. It is not for all clients, but if Shumani, upon further inquiry, was found to be a high-risk group for development of liver toxicity, then we would do an ALT. Can we address, colleagues, the issue of the gene expert ultra? I saw a comment from someone. Someone had said, let's do a gene expert ultra. But there's a comment from Sharon that
yes.
EXP is not necessary unless the patient is positive on screening or questioning. Colleagues, for the sake of time, let's conclude the GXP part. Remember that the people who are screened for TB with symptoms plus GXP are the pregnant women. So it is not a standard of care that everyone who is being screened for TB will have a gene expert. The gene expert for others other than the pregnant women is only done if we find that they have symptoms, any of their symptoms upon screening. So gene expert, not necessarily, unless if Shumani had TB symptoms. So the gene expert, we have covered that. Let me see what message we have. All right.
Adherence also, which is very important because he just started ARV, so that's quite important.
Yes, absolutely.
Yes, and can you just confirm that about the LEM test, because I think it's important also.
Oh yes,
and
someone
then you can
asked.
move on. Yeah.
Yeah, I think someone made a comment about the LEM test. Colleagues, that comment is correct. In individuals with a CD4 counts less than 200 in our program in South Africa, if you are suspecting TB, but you are struggling to confirm it, the client is ill and you are struggling to confirm or rule out TB with the sputum test, you can do a LEM. It's done on a urine sample. It has been found to have higher sensitivity in picking up TB in those who are having low CD4 counts. So colleagues, the LEM, if this client is presenting with symptoms and you are not sure whether there is TB or not, then we can proceed with the LEM. Colleagues, I'm going to move on. Dr. Mawela, is there another comment? I'm not seeing well.
No, I will just read it and then you can just proceed. So Dr. Komuto is confirming that let's not forget to treat patients comprehensively. It's a new patient, the CD4 count is low, so let's remember to exclude Cryptococcus as well. And also ask questions about cotrimoxazole at this stage, especially in terms of questions, allergy around that, but otherwise, all the things have been covered. Most of the key things were covered. So you can move on, I think, to the next slide. Yeah.
Thank you, Dr. So, Dr. Homoto, thank you very much. I was hoping we will prompt the court remoxazole with this note. Shumani meets eligibility criteria and has no contraindication to LTBI treatment. So colleagues, what we are basically saying, he was asymptomatic. He is not a heavy alcohol abuser. He has no pre-existing liver disease. Shumani is not, we've already established, is not initiating TLD. So he has no contraindication to LTBI. But we were going to prompt you in this other direction to make sure we manage our clients comprehensively. He has no known allergies to sulfur products. So colleagues, what do you need to give him, given this information? Dr. Homozo, let the cat out of the bag. What are we initiating Shumani on? Let me just exclude the issue of the cryptococcal latex antigen test and say it was negative, so that we know we don't have to deal with cryptococcal meningitis prophylaxis. But what do we have to deal with here? What are we putting him on before we let him go today?
Temba, we need more information. The question says drug names, doses, frequency, follow up. Yay. What's
Yes.
Shumani's weight? It's 50. Yeah.
Thank you. Yes, let's continue. Shumani's weight is 50. You did the full assessment and you documented his weight very nicely, 50 kg. Can I ask colleagues, can you give Shumani 3 HP? Or is he a candidate for IPT? Which one can we give Shumani? Okay. And specifically, let me ask, because we are in eThekwini and we've got 3 HP and we know it has a good, same efficacy, less side effects. So obviously we would want to start with that one. Can we give Shumani 3 HP? Dr. Lesego, what have we got?
You've got few. Oh, you're able to see. Okay.
Yes, now I can see. Zingiswa is saying 3 HP according to weight, once a week for 12 weeks. Sharon says no. So Sharon says we can't give 3 HP. Galaxy S8 says yes. Colleagues, let's take a quick vote. Can we or can we not give Shumani 3 HP? And why not? Just type it in if you are comfortable with the typing. If you want to speak, raise your hand and the host will allow you. Can we give Shumani 3 HP? Oh. Any takers?
No.
I miss face-to-face presentations. I can't read your body language.
Yeah.
Any takers, colleagues? Ah, thank you, Sean. Sean has commented, yes, no contraindications. Colleagues, I'm going to get on with it. In this case, we can give Shumani 3 HP. Remember, the regimen that he has been initiated on does not contain TLD. He is ART naive, but he's not initiating TLD. He's initiating TEE. So that's fine. And we have excluded all other contraindications. So we can actually give Shumani 3 HP. How do we administer the 3 HP? Someone commented, Zingiswa said 3 HP according to the weight, once a week for 12 weeks. So colleagues, let's clarify that according to the weight. How many tablets of INH, how many, and how many tablets of rifampicin, and what else should accompany that treatment? I'll suggest an answer. It's a lot of tablets at this point. How many?
Six plus 3, 9.
6 plus 3, 9 plus pyridoxine, colleagues, which makes it 10 tablets. I know it's unfair, colleagues, because you don't have the slides in front of you at this point, all of them. But the treatment we are going to provide is 3 HP, absolutely. Galaxy S8, reminding us not to forget the pyridoxine, 25 milligram. What other prophylaxis are we giving Shumani? Colleagues, for completion's sake, please don't forget to give Shumani cotrimoxazole, because he qualifies, absolutely, he qualifies for Bactrim. There we are. Yes, colleagues, absolutely, absolutely. So how do you instruct the patient? Now we are dealing with important issues around adherence and follow-up. What do you tell the patient? You've got the drugs in your, thank you very much. Isoniazid 900 and rifampicin 900 daily. We are going to initiate. Yes. We've got from Galaxy S8, have an adherence plan. Absolutely. Absolutely. We need to make sure the client completes the treatment. What do you say to the client, colleagues? The client is with you. What do you tell them? Take the treatment on the same day each week. Renee responded. If you miss the dose, take it as soon as you remember. Yes, explain what to do if they miss a dose. Yes, Renee was on to that one. If you miss the dose, take it as soon as you remember. And most importantly, do not take the 2 doses, the missed dose and the current dose together, colleagues. That one is very important. We are not playing catch up like that. Right, we've got the doses of the medication that we are going to prescribe. Colleagues, what else do you tell, do you instruct the patient? You've told them how to take the medication, what to do if they miss the dose. There's something about this medication, even though it's rare, that you need to alert them about.
Adverse events.
Adverse events. You need to tell them what to look out for and what to do in case they develop adverse. Absolutely. In case they develop any of the signs and symptoms you have talked to them about. Also, thank you, Galaxy S8. Also, advise them as to who to contact if they have any of the symptoms you've alerted them about, or if there are any worrying signs. Thank you, colleagues. I think we have covered quite a bit. Dr. Mawela, are you satisfied that we have not missed anything? Adherence is the word. Remember, colleagues, we also spoke about any changes. Thank you. Yes, thanks, Dr. Mawela. Any changes to their medication, social circumstances, if they are going to be moving. Before you even start, let's start right. Are they going to move? Do they have access to food? Absolutely. Yes. Dr. Mawela, you wanted to add?
No, I wanted you to read my comment, and I think you went through it. So yeah, it's exciting to do a case study over a live virtual session. Whilst we are edit colleagues, Dr. Nki, whilst she's still on board, are there any other questions you have about the treatment of latent TB infection? Any question you have where you need clarity? We just want to give maybe a minute or two to any question. You may raise your hand or you may type in. We just want to make sure that there is clarity about how to approach a patient who needs to be screened and to be initiated on latent TB infection. Any question that you might have, comments, before we hand over to the program leadership to make their comments and for a discussion around the way forward. Yeah.
And Dr. Mawela, the eThekwini district office have just commented that they will be disconnecting because they have another meeting scheduled.
Oh, okay.
Yes.
Yeah, maybe does Shumani have to stop ART whilst on TPT? The simplest answer is no, and they have to be given together. What I would like us to do, let me hand over before the eThekwini guys are off. Maybe let's start with eThekwini. Can you then share with us your views around implementation before you terminate your call, so that we can engage quickly on that, and then you can then be released. I'm not sure if you have already terminated already.
Is Sean still on? I'm going to stop sharing. Is Sean still on? He had posted the message that they are about to disconnect.
Yeah.
I don't think he's still on. I don't see him.
Yeah. All right. May we then hand over to Dr. Ngozo, and then she will share the way forward and maybe any other questions or clarities that she might need. And then we'll also hand over to the National Department of Health to say any other comments they might want to say. Dr. Ngozo, we hand over to you. Thank you.
Good afternoon, colleagues, and thank you